Welcome to another of the series of lectures in oral medicine, this one entitled Discolourations. First of all, we will begin this lecture with a case presentation. Here's a case of an adult patient that has noticed this discoloration on the buccal aspect of the tooth 2.5 and 2.6, and there is also ulceration and discoloration on the palatal aspect of those teeth. So what we know so far is this is a 57-year-old woman without antecedents of interest and subject to estrogen therapy, presenting with a black stain on the gums. The lesion had been present for the past year, and the patient is associated with endodontic treatment of the tooth 2.5. Intraoral examination revealed two greyish lesions measuring 2 by 4 millimeters in diameter on the buccal gingival zone of tooth 2.5, as well as a black pigmented ulcerated painful lesion measuring some 10 millimeters in diameter located on the palatal gingiva of the tooth 2.6. And orthopantography did not relieve anything significant bone alterations, and there were no palpable nodes. Again, the clinical picture. So what are the differential diagnoses and what other tests would you perform? Just take a moment to think for yourself on these two questions. So if we look at the biopsy results here, what the biopsy shows is this piece of mucosal tissue showing epithelium on the periphery with the underlying connective tissue and an area of pigmentation deeper in the connective tissue. And if we looked at that under higher power, you see some bizarre shaped sizes of cells as well as pigmentation, which can be stained to indicate whether they are melanin and or hemosiderin and or iron deposit. So different stains can be used to distinguish between these types of discoloration, and but putting the whole picture together with the bizarre cell types, it could be an indication this is a malignant lesion, showing large-sized atypical melanocytes, elongated nuclei, and abundant cytoplasm containing variable amounts of melanin as fine granules. So the diagnosis was the histopathology revealed the presence of a large-size atypical melanocytes with elongated nuclei and abundant pale cytoplasm containing variable amounts of melanin as fine granules located within the connective tissue component. Melanoma of the oral mucosa was diagnosed. In these cases, it's necessary to perform liver tests, radiographs and CT studies of the chest, abdomen and brain in order to discard the possibility of disease spread. Clinical examination of course also plays a fundamental role with determination of the characteristics of the lesion, the presence or absence of stellate lesions, ulcerations, etc. That may provide clues as to the type of process involved. Of note in our patients was that the presence of two types of lesions, a greyish macula on the buccal gingiva and a black ulcerated lesion on the palatal region. So that gives you some food for thought and an introduction into discolorations in the oral cavity. So what are some of the causes of discolored lesions? Blue, brown or black discolorations of mucosa constitute pigmented lesions and may be due to endogenous, such as hemoglobin, which can present blue, red or purple, hemosiderin, which presents as a brown discoloration, and melanin, which can be brown, black or grey. Exogenous causes may be traumatically deposited or ingested and then distributed hematogeneously. So chromogenic bacteria colonizing keratinized surface is also as seen in the case of a hairy tongue. So if we split the types of lesions into localized and generalized, a localized discoloration may be listed as an amalgam tattoo, a nevus, a Kaposi sarcoma, as with HIV and AIDS patients, malignant melanoma, as in the case outlined previously, pigmentary incontinence, where previous damage may cause melanin pigment to be spewed out into the surrounding tissue, so that when the healing occurs, it leaves a brown or dark discoloration. Poitz-Yerger syndrome is also can cause localized lesions. If the lesions are generalized, then that could be due to racial discoloration. The majority of people in the world have melanin pigmentation within the mucosa, and that can be varied depending on the level of pigmentation present. Localized irritation such as smoking, and this could be the discoloration due to the smoke, the contents within the smoke, or due to heat over a period of time. Medications such as antimalarials, Addison's disease can also cause generalized discoloration, and other causes. Putting it in a different way, in this diagram we have blue-purple. If it's focal, could be a varix or a hemangioma, a vascular lesion. And if it's diffuse, again, it can be a hemangioma. Multifocal could be Kaposi sarcoma or hereditary hemorrhagic telangiectasia. Brown lesions focally could be melanotic macule, a nevus, or a melanoma. Diffuse could be ecchymosis, which is extravasation of blood into the surrounding tissue, melanoma or drug-induced pigmentation, as well as hairy tongue. Multifocal could be physiologic pigmentation, neurofibromatosis, hemochromatosis, which is iron deposition, Addison's disease, medication-induced, or Poitz-Yerger syndrome, as mentioned before, or petechiae. Grey black lesions could be focally amalgam tattoos, a nevi or a melanoma. A diffuse grey-black lesion could be again amalgam tattoo, melanoma, or hairy tongue. Multifocal could be heavy metal ingestion or pigmentation. Hemangioma is a proliferation of vascular channels, often which regress after puberty, more commonly in the tongue. A varix is a focal dilation of veins or group of venules, mainly in the elderly, and so in this situation there's no muscular coat in the vascular channel. Hereditary hemorrhagic telangiectasia is a genetically transmitted, usually occurring under 0.5 of a centimetre in diameter, multiple microaneurysms caused by weakening defect of the adventitial coat of the venules, and you may have greater than 100 purple papules on the tongue and vermilion of the lips. Hemochromatosis involves deposition of hemosiderin pigment in multiple organs, primary, heritable, secondary due to chronic anemia, porphyria, or cirrhosis, and excess intake of iron. Mainly due to iron deposition, but bacillar melanosis is also observed, and you can stain for this with Prussian blue. Ecchymosis, or due to erythrocyte extravasation, and petechiae due to capillary hemorrhages, will resolve generally in 2 weeks and changes colour from red to brown after a few days. Other discoloured lesions, anaphylis, or more commonly called cutaneous freckle, melanotic macule, is a increased melanin pigmentation synthesis by the basal melanocytes. Nevocellular nevus, or a blue nevus, due to benign proliferation of melanocytes. Here it's an increase in melanocytes, whereas the other epiphysis and melanotic macule are increasing the melanin pigment. So nevocellular nevi arise from the basal layer early in life. Blue nevus arises in the deep connective tissue, so it's a deeper lesion, and the overlying vessels dampen the colour to blue. Racial pigmentation often is symmetrical and may become only apparent later in life. Here's an extreme case of melanin pigmentation of the gingiva. Pigmented nevi, as genetic in origin, especially occurs in the vermilion border of the lips and in the palate. Excisional biopsy, often for cosmetic and to rule out malignancy. Malignant potential occurs especially at the junctional nevi. Here's an example of a pigmented nevi. Amalgam tattoo, the particles or dust in wounds after extraction or apicectomy or during placement of an amalgam restoration. The black-blue pigmented area may show up on radiographs, but it could be often faint, so you need to look carefully into the corresponding area. May require excision to exclude melanoma if otherwise you can't detect it clinically. Addison's disease, which is a adrenocortical hypofunction, typically occurs in middle-aged women. Granulomatous infection of the cortex or autoimmune destruction of the adrenal cortex, leading to then adrenocortical insufficiency, causing an increase in adrenocorticotropic hormone secretion through the feedback loop, if you remember back to your physiology. Brown pigmentation of areola of nipples, genitalia, skin flexures, sites of trauma may occur, may get weakness, anorexia and low blood pressure, collapse under stress, Nelson syndrome. Addison's caused by can be also caused by adrenalectomy for breast carcinoma management. Treatment is by replacement fluorocortisones and glucocorticoids. In comparison, in Cushing syndrome, there is an adrenocortical hypersecretion, cortical secretory due to a cortical secretory adenoma or hyperplasia, or as a result of a primary pituitary ACTH secreting tumour. Addison's and Cushing's cause hyperpigmentation through increased ACTH secretion, which stimulates melanocytes. HIV oral melanosis is similar to Addison's but caused by opportunistic infections of adrenal cortex. Kaposi sarcoma is an unusual vascular neoplasm which may be classic or endemic as in African, iatrogenic due to immunosuppression and HIV or AIDS related. Mainly occur in men, slow-growing, painless nodules, mainly palate. Histopathology will show slit-like vascular spaces, extravasated erythrocytes or red blood cells, and spindle cells. Management may be through radiation, surgical excision and or chemotherapy with vinblastine, intralesional injection of chemotherapeutic agents for individual lesions. It is associated with the human herpes virus 8. Poitz-Yerger syndrome is characterized by freckling of the lips and hands, perioral skin, oral mucosa, as well as intestinal polyposis. These polyps may have a predisposition to develop cancer, so it needs to be managed by specialists. Autoimmune, it's an autosomal dominant with gene mutation of LKB1, GI, gastrointestinal adenocarcinoma can occur in 2 to 3%. Brown to blue grey macules, vermilion skin, oral mucosa and tongue, and what you get is bacillar melanogenesis. Melanomas are the most aggressive form of skin cancer with great metastatic potential. 3 to 5% of all skin cancers are melanomas, 1% of all malignancies. Both sexes are affected equally. Oral mucosal melanomas are less common, 0.5 to 2% of all melanomas, and mainly in 50 to 70-year-olds, more common in Asians and Africans. Palate and the gingiva are the most common sites. Risk factor for skin is prolonged solar exposure, and quite common in places like Australia and New Zealand. whereas in the oral cavity it's from a pre-existing melanosis. Treatment of melanoma can be a stage 1 and 2 are amenable to surgery, and survival can be 15% for 5 years, 85% relapse after 2 years. Stage 3 is mainly palliative management. Liver and brain metastases are common and have poor prognosis. These are some examples of discolored lesions, melanoma, and you get an H&E staining, hematoxylin niacin stain showing the melanocytes, the abnormal melanocytes, and they can be shown through S100 staining as well. So with the melanoma you can also use melanoma specific antigen for staining, S100, as well as HMB45. And what you see here is the tumour cells, which are bizarre looking pagetoid groups of tumour cells here, and at the surface is the stratified squamous epithelium. Thank you.